Good evening, everyone. How are you all? Welcome to First Aid AMC Clinical, 2 weeks free session again. So as you know that this will be our last session of those free 2-week session. And tonight we are going to cover pediatric vomiting cluster. So far we have done a couple of theory sessions. We have done few role play sessions. I'm sure that you have an idea how the course is going to be and how we are taking the classes. So throughout this 2-week session, which we have started in November, you had psychiatry session with us, one theory session followed by a role play session. Then you had some random role play session with us, and one of them was taken by Dr. Cynthia. Then you had cardiology session with us that gives you an idea how medicine cases usually comes in exam. And also tonight you're going to have an idea about pediatrics. Pediatrics is very important part of your exam preparation, and you will come to know that it's a vast preparation. If you're asking me that which has the most cases for clinical exam preparation, I would say pediatrics and medicine. So these two has like a lot of cases to go through. And for your benefit, we have divided pediatrics in a lot of classes, but we have done in a way so that it falls under all cluster. So you can just have one history format in your head, and you can use it for even sometimes 10 cases. So today you will see how we use that. You have some idea from our cardiology class as well. All right, so let's start our tonight's session. And the reason you are getting back-to-back classes this week is that we just had to take some extra session this week because of coming Christmas. We don't usually take sessions during Christmas. So Saturday, they were supposed to have your class, which was tomorrow. So we just made it today so that you can have some time off from study. You can give some time to your family members during this time. All right. And also the Sunday class has been already taken by Dr. Cynthia yesterday. So that's how we have managed the sessions just during this break time. So usually that happens in the course as well, that if we know that some public holiday or some celebration coming up, we usually will just take the sessions as an extra session so that you guys don't miss any classes. Okay, so let's start our tonight's session. So today's session is about pediatrics vomiting cluster. As always, when we come to any cluster, we use some differential diagnosis. So what are the differential diagnosis of a child coming to you for vomiting? So it can be GIT related causes, can be non-GIT related causes. What are the GIT related causes? It can be gastroesophageal reflux, pyloric stenosis, it could be duodenal atresia, incarcerated hernia, intussusception, can be intestinal obstruction, volvulus, Hirschsprung disease. Sometimes it can be just a simple gastroenteritis. Sometimes can be esophageal atresia or tracheoesophageal fistula. What are the non-GI causes? Can be UTI, torsion of the testis for male child, otitis media, septicemia or meningitis, and can be due to pneumonia. So non-GI causes, we always try to rule out in pediatrics, especially in infant and neonate, because that's the population who has a lot of unusual symptoms and you don't know actually what's going on because they can't actually say what's happening. So we always try to rule out non-GIT or infective causes if a child is vomiting. Okay, so whenever a child is vomiting, you first think about we are going to rule out some GIT related causes and some non-GIT related causes. In terms of non-GI causes, all are infection. So urinary infection, chest infection, ear infection, or blood infection like septicemia. Okay. For the purpose of exam, the important cases are gastroesophageal reflux. Very important is pyloric stenosis. Also important, duodenal atresia. Incarcerated hernia also important. intussusception important. Sometimes I have seen intestinal obstruction, gastro not too much, and also esophageal atresia important. You can see how much important this cluster is, right? So all of these are exam cases, so you'll need to have a good idea. UTI also very, very important for exam. It can come as a lot of ways, sometimes burning discomfort, sometimes like child is unwell or child is very irritable, sometimes just with vomiting. And others, usually meningitis or septicemia also comes, but not as just vomiting, like a generalized drowsiness, unwell, those kind of symptoms will be there. So you can see that this cluster is super important for your exam. Moving on to the history format. So what you are going to see tonight is that just by using a single history format, you can use that same format for all these cases. Okay. So when you start history in pediatrics, there will be no child in the exam room. So parents will be there, just one parent, either a father or mother will be there who will talk to you. So there will be no child in the exam. When a parents come to you for a child who is vomiting, they are already very stressed. So you are supposed to show them enough empathy and reassurance before you start the case. And because it's vomiting, make sure child is vitally stable before you start the case. So let's say that a child is coming to you with the parents for vomiting since 2 days. What are you going to do first? So your approach will be like, hi Sam, this is Dr. X. I'm one of the GP in this clinic. It's very nice to meet you. I understand from the notes that your child, or you can say your son, David, is having vomiting for the last 2 days. I'm very sorry to hear that. It must be very stressful for you. But now that you are here, I'm going to take care of your baby and we are going to find out why he's having this vomiting. Now, before I ask you any more question, I would like to talk to my examiner to make sure he is vitally stable. So please excuse me for a moment. So then you turn to the examiner and ask that hemodynamic stability question. Come back to the patient and say that, thank you so much for waiting, John, or thank you so much for waiting, Sam. So now that I confirm that David is stable now, I would like to know a little bit more about this vomiting. So would you please tell me a little bit more about it? Always open-ended question. So then the parents will say that, yes, doctor, this is happening. So you will get some information from them. So what information you need, so whatever they don't give it to you with that open-ended question, just ask the others. Now, very important is that when you remember a note or follow a format, you just follow it. You don't use your brain. Like if the patient say or the parents say that, doctor, it's been going on for the last 2 days, or in the stem you have already seen that it's been for 2 days, do you need to ask this question that since when? No. So always important to look at the question, important to hear what's the role player giving to you. So don't repeat that question. It sounds so bad in the exam. Like if the role players say that, doctor, he's been vomiting everything that we are giving, it's been going on for 2 days. And the next question that you are asking, so since when it is started or how long it's going on? So that means that you did not even care about what the role player just gave it to you. So examiner, like, I don't think anyone like that. So make sure that you always follow this approach, that if something is given to you by the stem or by the role player, don't ask it. So we need to know about, like, when did it start? Did it start suddenly or gradually? Not very important question here though, but we need to know that how many episodes so far. We always follow CCVO for any kind of discharge coming out of the body. So vomiting is kind of a discharge. So ask about color, consistency, volume, and order. So what's the color of the vomitus? Have you noticed any blood in it? Consistency, now in here, you don't need to ask that is it a thick or thin in consistency. Rather, ask that what's the content of the vomitus? Okay. Volume, is it a small or large in amount? And is it very foul smelling? Is it forceful or projectile? Now that's a very important question because forceful projectile vomiting suggests possibility of pyloric stenosis. That doesn't mean that every child who is having a forceful vomiting will have a projectile, will have a pyloric stenosis. It always depends on the whole scenario. Sometimes if you ask, what is, have you noticed any projectile vomiting? Then the role player can ask you, what do you mean? So you need to then just make it more clear for them that does the vomit, is the vomiting is forceful? Okay. So forceful or projectile, if you ask, then you will not get any question back from them. So ask that is it a forceful or projectile vomitus? Any relationship to food or feeding? Sometimes if a child just vomit immediately after having a food or drink or having a breast milk, it suggests the possibility of pyloric stenosis, or sometimes if it's a 24-hour-old child, like a neonate, suggests possibility of duodenal atresia or esophageal atresia. So we just need to find out that is there any relationship to feeding? If yes, how long after feeding does he vomit? And is he hungry immediately after feeding, or does he cry immediately after feeding? So if he cries immediately after feeding, it means that everything that you have given just came out of the vomiting. So he's not able to keep anything down below. So these are the questions for vomiting that we are going to ask first. So first CCVO, then forceful projectile for pyloric stenosis. We need to know any relationship with feeding, and if yes, how long after feeding, and is he hungry immediately after feeding? Next, we always ask some associated symptom with the presenting complaint. So in here, the presenting complaint is vomiting. So along with the vomiting, have you noticed any swelling or distension of the tummy? Any lump or bump in the tummy or in the groin? If you don't want to remember associated symptom, you can just keep it in the differential diagnosis also, because we will ask this question in the DD as well. So now is the questions for all the differential. So ask about bowel habit and waterworks first. So how about his bowel habit? When was the last time he passed his stool? Any history of diarrhea or constipation? Okay. Then to rule out UTI, how about his waterworks? Any change in number of wet nappies? Any change in color or smell of the urine? And does he cry while passing urine? So a lot of things are very new for you. We use the term waterworks. We don't ask micturition or sometimes even not urination. Urine they understand, but sometimes for urine we just ask how is his pee and poo. That's also very commonly asked thing in here. If you don't want to use that, ask about bowel habit and waterworks. So for intestinal obstruction, we are asking about the bowel habit. We are asking about when was the last time he passed his stool. That's important. If you forget about this question here, you can ask it here because that's also another symptom of intestinal obstruction. So any distension of the tummy. Any diarrhea or constipation. Constipation is a feature of intestinal obstruction, whereas diarrhea, one of the DD is gastroenteritis, right? So that will be covered by this. Then another differential diagnosis is UTI. So you're asking about waterworks. You're asking that does he cry while passing urine? That's dysuria, which can be a feature of UTI. Now, a child who is vomiting can get severely dehydrated. So to find that if the child having dehydration, we ask this question, any change in number of wet nappies? If they say, yes, doctor, there is reduction of amount of wet nappies, it suggests the child is dehydrated. And any change in color or smell of the urine, sometimes children with a UTI, their color and the smell will be a little bit unusual, or it will be very smelly urine. So that's for UTI. After you have asked about bowel habit and waterworks, then you go for other DDs. So ask about intussusception. Does he draw up his legs while crying? And does he turn pale while crying? So in intussusception, they will come to you with a paroxysmal attack of sudden onset screaming, as if child is in severe pain. And during those screaming, they will draw up their leg up to the chest and sometimes even clench their fist. And that's usually a very common feature of intussusception. And during that time, they can turn pale or blue. Sometimes you can notice some blood in the stool also. So you can ask about it. So have you noticed any episodic screaming? And during that screaming, does he draw up his leg up to the chest? Does he turn blue or pale during that time? Have you noticed any blood in his stool? Okay, so that will be intussusception question. After that, couple of non-GIT causes. So ask about septicemia or meningitis. So any fever, rash. For otitis media, have you noticed that he is pulling his ears a lot? Or if the child is a little bit older, like if it's a 4 or 5 year old child, they will complain ear pain. So is there any ear pain or ear discharge? For pneumonia, any cough, any difficulty in breathing? So that's all the differential diagnosis that you need to ask, right? So if we go back to the DD, you can see that we have asked almost all of the differentials from here, just by the format. For gastroesophageal reflux, only finding will be child vomits after feeding. And most of the time, they will say that child barfs a lot. For pyloric stenosis, we know that child will vomit every time you feed them, and it will be a bilious vomiting, like a bile-stained vomiting. And you can also find out that child having a forceful projectile vomiting. Duodenal atresia, usually the finding is it's a neonate immediately after feeding, child having a non-bilious kind of vomiting. Incarcerated hernia, you already asked, remember that, have you noticed any lump or bump in the tummy or in the groin? So that's groin lump is for hernia. If you have missed this associated symptom question, then just add this incarcerated hernia after intussusception. Okay. We already know about intussusception question. We asked about intestinal obstruction question. Gastro question we asked by diarrhea. Esophageal atresia, again, it will be the more or less same symptoms. So neonate immediately after birth start to vomit. That's esophageal atresia is the possibility. We asked about UTI question. We asked about otitis media, meningitis, and pneumonia. Torsion of the testis, there is nothing to ask in here. But if it's an older child, you can ask that, does he complain about any pain in his groin or in the testis? Okay, so you can see that just by asking this format, it covers almost all of the differential diagnosis anyway. Now, after differential diagnosis, any pediatric questions will be finished by these questions. So we have some well baby question, BINDS, TMAC, past medical history, and family history. Now you will get a lot of idea about these questions once we come to the pediatric respiratory system. But tonight I will just give you some idea about it. So, and also you will get the full notes about this thing in the respiratory system note. So well baby question means that we are mainly asked about 4 to 5 questions. So first question is, how is his mental status? So we just ask the question that, is he active, alert, or drowsy? So that's one thing we want to know. So mental status, active or drowsy. We also want to know that how is his feeding and sleeping. We also need to know that how is his pee and poo, which we already asked, so no need to ask it again. And very important question, have you noticed any loss of weight? So these are the well baby questions that we ask to every child. Okay, so sorry, active or drowsy, how is his feeding and sleeping, how about his pee and poo, and any loss of weight. Then we go for the BINDS. BINDS is a mnemonic for birth history, immunization, nutrition, growth and development, and social history. So that's called binds. Now we don't ask every questions to every case. It's just a relevant question. Like for a child who is vomiting, birth history is an important thing. Immunization is important. We already asked about feeding, sleeping. So nutrition, even if you don't ask it, that's fine. Development is important. And social history, not very important for someone who is vomiting. So forget about it. So for birth history, we will be asking that how is his birth or how was his birth? Was he a term baby or preterm baby? Was there any complications during pregnancy, delivery, or after delivery? Okay. And was it a normal or cesarean section? Now, those are also not super important. If you're running out of time, just ask one question from the birth history. How was his birth? Was there any complication? That's all. If you have some time, then you will ask a little bit more, like how was his birth history? Was he a term or preterm baby? Was there any complication during pregnancy, delivery, or after delivery? And sometimes you even ask that, did he cry immediately after birth? Did he need any resuscitation after birth? So a lot of questions are there which you will come across in our respiratory system questionnaires. Okay, so that's birth history. Followed by, we ask about immunization. So is he immunologically up to date, or has he got all the vaccinations according to his age? How about his growth and development? It's very important to know about weight loss and development or growth problem for a child who is vomiting for a long time. If a child losing weight because of vomiting, it suggests the possibility of pyloric stenosis. That's a very important finding which lead you to think that it's not just gastroesophageal reflux, it might be pyloric stenosis. Okay, so growth and development, loss of weight is very important question. So that you will ask from binds. Should we ask about birth and immunization for older children? Usually for a 10, 12-year-old child, you don't need to ask about birth history. But 3, 4-year-old, still you can ask about their birth history. Immunization history is for any child, we ask it. Okay. Development, again, for maybe just for 3 to 4-year-old. For 6, 7 years, or even 10-year-old, you don't need to ask their development. But any loss of weight, we will ask. Okay, so it always depends on the age of the child. A lot of questions will be changed. So that's binds, followed by TMAC. So what is TMAC? TMAC is travel history, M for medication history, A for any allergies, and C for contact. Contact is very important for a child. And also we need to find out, does the child go to the child care? So for vomiting, we can ask that any recent history of any travel, any medication or any history of any allergies, any contact with someone having similar complaint, especially does he go to the child care, anyone in child care having similar symptom, and anyone in family having similar symptom. So that's contact history. So for contact history, if you're running out of time, only one question. Has he had any contact with someone with the similar symptom? If you have some time, then we ask a little bit more. Like, does he go to the child care? Anyone in child care having similar symptom? Anyone at home having similar symptom? So that's TMAC. And lastly, just finish with any past medical history, any family history of any chronic condition. Okay, so that will finish your pediatric history. Time to time, according to the number of tasks, according to your time, you will change the format by your own accord. So this is not like something which you can't change. You can always change it according to the number of tasks, according to how fast you are, how conveniently you can ask this question, you can change it. Okay, so if we go through the summary of this vomiting cluster history, first of all, introduction, reassurance of the parents, vitals, then ask about the HOPC, which is the vomiting questions, followed by associated symptom, then all the DD, starting with the bowel habit, waterworks, then intussusception. You can put incarcerated hernia here, and then the non-GI causes like meningitis, otitis media, pneumonia. Then well baby question, binds, TMAC, past medical history and family history. Okay, any question for the history, guys? All right. So that's all about the history that you need to know for this vomiting cluster. We'll come to the physical examination when we do the cases. So let's start the cases. The first case that we are going to discuss tonight is the urinary tract infection, very important for your exam. So a mother came with a 9-month-old female baby with fever and vomiting for the last 2 days. And you are a GP, take history from the mother, physical examination from examiner, diagnosis and further management. All right, so that will be your case. So when you take history, the format is same like what we have done. So first of all, use the same approach. Start with the presenting complaint, so vomiting and fever. So in here you have got 2 presenting complaint. When you get 2 presenting complaint in the exam, we always ask that, I understand from the notes that your child is having fever and vomiting. Can you please tell me which one started first? And then you start that. So let's say they said fever started first. So what are the fever question we are going to ask? So since when? It is continuous or on and off? Any chills or shivering? Did you measure the temperature? Have you given any medication? If yes, then did it help? So that's the fever question. And then you ask the vomiting question like before and ask all the differential diagnosis. Now, when you already know that this is likely to be an infectious cause of vomiting, because child already having fever, it's a good idea to start asking the febrile question or non-GIT question first. So we always use this thing called head to toe fever source question. So we want to find out from where the fever is coming. So a child can have infection in a lot of areas. So we will use this head to toe format for almost every child who is having fever. So what we do, we will rule out otitis media. So first start with meningitis. So any fever, rash or vomiting. If it's an older child, you can also ask about headache. You can ask about photophobia, like does the light hurt your eyes? Okay. So for meningitis, the main question is fever, rash, nausea, vomiting, headache, photophobia, and also neck pain or neck stiffness, depending on the age of the child. All right. So that's meningitis question. For otitis media, you already know viral upper respiratory tract infection. So we ask about any runny nose, any sneezing, any watery eyes. All right. You can also ask about any sore throat. So that will be your upper respiratory tract infection question. So sneezing, watery eyes, or runny nose, and sore throat. For pneumonia, any cough, any shortness of breath, you can sometimes ask about any noisy breathing or any wheezing. That's for any other like a bronchiolitis or asthma. Acute gastroenteritis, you ask about the bowel habit question here. UTI, you ask about the water work question here. And then you just follow the same format. So ask about hernia, intussusception, and all other GIT differential diagnosis. And lastly, finish with this well baby binds, TMAC, past medical history and family history. If you know that it is UTI, then ask about past history of urinary infection or any other kidney disease and family history of kidney disease. Okay, so that will be your history here. Physical examination. In physical examination for vomiting cluster, we will use this one for everywhere. So first start, dear examiner, I would like to do physical examination on my patient. On general appearance, is the child active, alert, or drowsy? Any dysmorphic feature of Down syndrome? Then we ask quickly pickles. So any pallor icterus, any cyanosis, any lymphadenopathy, any sign of dehydration. Sign of dehydration for a child who is vomiting is must. If you miss that, they don't like it. Okay. So sometimes examiner asks you that what are you looking for when you ask about sign of dehydration? So for sign of dehydration, we look for capillary refilling time, skin turgor, sunken eyes, any dry mucous membrane, and if the anterior fontanelle depressed or not. So that's the sign of dehydration. Ask about any rash, any skin pigmentation. So that will be covered in all your general appearance. So ask the mental status, dysmorphic feature of Down syndrome. Quickly ask about pickled, don't forget dehydration. And lastly, rash and skin pigmentation. Skin pigmentation is not very important. So even if you don't remember it, that's fine. After general appearance, ask about vitals and growth chart. So vitals, same like before. In here, temperature is important because the child might have fever. Now, don't forget to ask about growth chart in a child in exam. Any pediatric case, if physical examination is a task, growth chart is must. All right. In this case, it's must because if it's a pyloric stenosis case, you can see that there is a decline of child growth. So that's a very important finding in this cluster. So vitals growth chart, how you ask about growth chart to the examiner. So say that, like, first you'll say that, dear examiner, I would like to do physical examination on general appearance. Is the child active, alert, or drowsy? Any sign of dysmorphic feature of Down syndrome? Then pickled, any rash? I would like to know about the vitals, please. First pulse and blood pressure, then ask about temperature, respiratory rate, and saturation. Don't say RR. I've seen a couple of you asked RR in our previous role play session. Examiner don't know what is RR. Say respiratory rate, okay? Then ask about, like, is there any growth chart available? So if growth chart available, then examiners say that yes, the child is in 50th percentile. As long as child is in between 3rd and 97th percentile, you are not worried because that's normal. If it's less than 3rd percentile, child having decline or loss of weight or failure to thrive. So that's the time you will be worried. So that's growth chart. Growth chart for a child, you ask it until 12 years of age. After 12 years of age, you use the term BMI. Once you have done the growth chart, then go to the whole ear, nose, and throat. So ask the examiner that I would like to do the head to toe systemic examination, but first I would start with ear, nose, and throat examination. So in the ear, now again, this ENT examination will be fully discussed in our respiratory system. So just have an idea tonight. So in the ear, what you will be asking, so say that I would like to do ear, nose, and throat examination. In ear, is there any discharge, any tympanic membrane changes? Okay. Then for nose, any nasal discharge, any nasal mucosal changes. For throat, any tonsillar hypertrophy or exudate, okay, and any pharyngeal erythema. So for throat, normally you ask about any tonsillar hypertrophy or any exudates and any pharyngeal erythema. So that's your throat. Once you have done the ENT, then you go for neck stiffness. After neck stiffness, then you go for that systemic examination. Now for systemic examination with vomiting, the main system is abdomen. So you will do the focused abdominal examination. Just like in cardiology, you did focused cardiology examination and other system you just did very short. This In here, also abdominal examination will be detailed. The other system you can just do very quickly. So on inspection, any visible distension, any visible peristalsis or mass. On palpation, any palpable mass or tenderness, and on auscultation is the bowel sound audible. Now, inspection is the most important thing because in here, if it's a pyloric stenosis, you might be able to see some visible peristalsis. If it's an intestinal obstruction, you can get the visible distension. On palpation, you can feel some mass. If it's a pyloric stenosis, you can feel a mass. Sometimes in intussusception, you can feel a mass. Tenderness, you can ask. Auscultation bowel sound is important for intestinal obstruction. After you have done that, the next is very important. Always, if you need to look into the private part of anyone, even if it's a child, you need to take consent. So you can't take consent from the child, so take it from the parents. So say that with the consent of the parent, I would like to check the hernial orifice, genital examination to rule out any torsion of testis, and per-anal inspection for any red currant jelly-like stool. So what did I say? Hernial orifice, why? Because one of your DD is incarcerated hernia. Genital examination, why it is important? To rule out testicular torsion. Sometimes congenital adrenal hyperplasia child can come to you with vomiting. And if it's a female child, you can get a ambiguous genitalia in congenital adrenal hyperplasia. Never came in the exam, don't bother too much. Per-anal inspection, why it is important? Especially if it's like a diarrhea or prolonged constipation child, can have anal fissure, can have anal tax. But for this case, the important thing is intussusception child can have a red currant jelly-like stool. So that's why we are doing the per-anal inspection. We don't do DRE in a child, okay? And then say that I would like to finish with all other systemic examination like respiratory system, cardiovascular, and central nervous system examination. You don't need to ask this. And say, is there any office test available like urine dipstick? You can ask about blood sugar level also because any child who is vomiting, they can develop hypoglycemia. So urine dipstick and BSL. The main is urine dipstick because you might get some finding here. So what are you looking for? You're looking for any leukocyte, nitrite, and any RBC. Okay, so that's your physical examination from examiner for this case. Neck stiffness is usually positive from 18 months of age. So if it's less than 18 months, don't bother with neck stiffness. Now, features of Down syndrome, it is important in here because Down syndrome babies have weak muscles and they have feeding difficulty. So they vomit they vomit immediately. So, and especially for all pediatric child, like if it's an infant, we ask this, like any features of Down syndrome anyway. But for this case, yes, it's important because Down syndrome child can have difficulty with feeding and they can have vomiting. All good, guys? Did you guys understand the physical examination? Because we will follow this physical examination for every vomiting cluster. Now the management. So you've done the history, you have done the physical examination. Now it's management. So you have got that child is having like some unusual smell from the urine, having fever and vomiting for the 2 days, and also child cries during passing urine. And in the urine dipstick, you found there is some leukocyte and nitrite. So that confirms your diagnosis of UTI. So most likely your child is having a condition called urinary tract infection. Do you know what it is? Well, if patients say no, then you can say, well, let me discuss it in detail. So it's an infection of the urinary tract caused by a bug or a bacteria. Let me draw a picture for your better understanding. So you can say that this is kidney, and then this is a pipe-like structure which takes the urine from the kidney into the bladder or water bag, and then it goes out through the water pipe. And that consists of your urinary tract as a whole. Now, if there is any infection in this urinary tract, that is what we will call as urinary tract infection. In female, this tract is very close to their back passes, so bugs can easily enter into this urinary tract, and then it can even ascend upward, causing infection and inflammation, which manifest as fever, vomiting, with some painful, smelly urination. Not only that, because when we have done the urinary dipstick test today, we have found some infection cell in her urine. So that confirm that most likely goes with the possible urinary tract infection. You will always say most likely because you haven't done the microscopic culture yet. Now, this child is 9 months old. Anyone less than 12 months having any kind of infection, they are considered to be a vulnerable group or risky group. So for a 9-month-old, you would send that child to the hospital, especially if they're having high fever and if they are vomiting everything, or if there is a sign of dehydration. So say that as your child is still 9-month-old and it is considered to be a part of the vulnerable group of patient, I would like to send her to the hospital via ambulance. In the hospital, she will be seen by a registrar and a child specialist for further evaluation and management. Now, when you say urinary infection, in here just say that please don't get scared. It is a very common infection and it can be easily treated. So always when you say something like it's causing infection, parents will be very stressed. So say something reassuring in between. So as the urinary dipstick is just a screening test for infection, most likely in the hospital, they will need to take another urinary sample, probably by a method called suprapubic aspiration. And then they will send that urine for culture to confirm the diagnosis. In this procedure, a small needle will be passed just below her belly button, and a sample of urine will be collected from there. Please don't get stressed because it will be totally pain-free and will be done by a very experienced doctor. But now, when you say something like that, they will just become very stressed because you are talking about passing a needle into just a 9-month-old baby, right? So just say this line that please don't get alarmed. It is totally pain-free and it will be done by an experienced doctor. Now, if they can ask that, is there anything else that we can do? Now, a lot of things can be done nowadays. Like there is a possibility of a clean catch urine. If parents are able to do the clean catch urine, then we can do it. But for a 9-month-old, like less than 12-month-old, there is no other way apart from suprapubic aspiration. Okay, so whatever way you are doing, it most likely contaminated anyway. If you're doing a clean catch urine, if you're doing a bag specimen, whatever you are doing, it will be likely to be a contaminated specimen. So for less than 12-month-old, suprapubic aspiration is the ideal one. But when it becomes 1 to 4 years of age, you can give it a try with, like, sometimes there are clean catch urine that can be done. If child is able to void on request, then parents can just catch the urine and then then they don't need to do the suprapubic aspiration. More than 4 years of age, then you can do that midstream urine anyway. Okay, so it depends on the age that you get in the exam. If it's 1 to 4 year old, just ask the mother that, do you think your child will be able to pass urine? If you request and you will be able to catch the urine, then we can just send that urine to the microscopy to confirm the diagnosis. Okay. If they ask that, is there any possibility of doing a bag specimen? Say that, well, bag specimen is not usually reliable because it can easily get contaminated and compromise our test result. Then for further management, specialists, once they take the urine and send it for culture, microscopy and culture, most likely the specialist will start your child with an antibiotic to fight the infection. And if she's still having fever, then they can give some Panadol to address her fever. Up to this is usually the management for the first time urinary infection. If a child gets recurrent UTI, then sometimes the specialist can do further investigation. So say that it is usually the choice of the specialist that if they want to do any further investigation, but usually if a child gets recurrent infection, they might want to do some further investigation to exclude any structural abnormality in her kidney, ureter, and bladder, or in her waterwork or urinary tract. First of all, they might want to do an ultrasound of her urinary tract to rule out any structural abnormality. In very few children, specialists might also want to do another test called micturating cystourethrogram, in which a special dye will be inserted into the urinary tract looking for any other abnormality. But these are all decided by the pediatrician. So what is important in this case is that we have seen that if you don't say these things, the examiner fail you in the feedback. But the thing is that usually for first time urinary infection, usually we don't do this kind of test. But if the child gets recurrent UTI, then only we go for it. But it's a good idea in the exam, just say that it's unlikely that a specialist might do this further investigation, but it all depends on them. If they feel it's the right choice for her, then they might do further ultrasound of her urinary tract to rule out any structural abnormality. And if needed, then they might also want to do a dye test to look for any kind of structural abnormality of the urinary tract. Okay, but it's usually done when a child gets recurrent urinary infection, but it will be decided by the specialist. And lastly, just finish with some reassurance. Please don't worry. Most of the children with this kind of infection make a good recovery and have no future problem. To prevent it further, please wipe from front to back, give her ample amount of fluid, and then once the hospital manages her symptom, or once she is treated in the hospital, please come and see me for further review. At any time, if you notice these things happening again, or if she have high fever, she's started to have feeling like if you see that she's getting very drowsy or lethargic, please bring her immediately. Either you go to the emergency or bring her to us. Okay. And lastly, give some reading material. So that's 4R, right? So in the 4R, you give reading material. You are already referring the patient to a hospital. You told that you are going to review the patient after discharge from the hospital. Okay. And you also gave some red flag. So that's how you will finish this case. This case does not come as history, physical examination, diagnosis, management. Very unlikely, because it is difficult to finish in that way. But if it comes, then you will need to cut it short. Okay. Clean catch urine is usually it is done by someone else. Like you are urinating and someone else is catching it. And there is a chance that if you do it, child might not be able to do it as a midstream, because a 1-year-old may not even understand that how to hold the urine and then pass a little bit of urine, then do the midstream. So clean catch urine is that you don't touch the bum, you just, while the patient is passing urine, you just try to catch it. Okay. So that's how you do it. And midstream urine is like that if the child is able to do it just during the midstream, if they can collect it. So clean catch means that it does not need to be midstream. All good. So that's all about this UTI. Any questions so far, guys? You are understanding? I know that this is quite new for many of you, but have some idea you can use this for many, many cases in the future. Moving on to gastroesophageal reflux. Gastroesophageal reflux also an important case in exam. Now, time to time you use the term gastroesophageal reflux disease, right, in adult. But in case of children, we use the term gastroesophageal reflux. If we use the term reflux disease, that suggests something more worse, and it suggests pathology. But just gastroesophageal reflux is a physiological phenomenon which can happen in a child. So you are a GP, a mother brought her 4-month-old baby girl since the child after feeding. There are no other symptoms. Mom thinks that the bottle feeding will be better for him. History, physical exam, diagnosis, and management is the task. So let's have some idea what is reflux and what is reflux disease. So gastroesophageal reflux means that is the passage of gastric content into the esophagus. It is a physiological process that occurs several times in a day in a healthy child. And in this case, child will just have little bit of vomiting or regurgitation of the foods. In majority of cases, it's self-resolving, does not need any treatment. At 12 months, only 5% child will have this kind of symptom. But when we call gastroesophageal reflux disease, it means child will have reflux, but along with that, these features will be there. So pronounced irritability with arching of the back, refusal to feed, weight loss or crossing percentile, hematemesis, chronic cough, wheezing, and apnea. So these are the questions that you need to add in your history. The positive findings in this case was like child vomits after feeding, and it's just milk, sometimes gets projectile, but child is gaining weight. So the important thing is that child is gaining weight. If it's gaining weight, never think about pyloric stenosis. All examination is normal, no other sign of gastroesophageal reflux disease. Now, that means that you will ask all the history format of vomiting cluster that you have done, but you just add these questions. Like, let's see that what you have already asked a couple of questions from your format anyhow. So pronounced irritability. So when you ask that, how is your child mental status? Like, is he active, irritable, or drowsy? So that's irritability will come here. You can just ask that, have you noticed that your child gets arching of the back? Okay. You're asking about feeding and sleeping in the well baby question. So that will be covered. You're asking about weight loss in the well baby question, though that will be covered. When you ask about CCVO, you ask about color of the vomiting and any blood in it. So that's hematemesis. Chronic cough, wheezing, and apnea. Now that's the only thing you will need to add. So ask them, like, have you noticed that he's having chronic cough? Any musical sound or unusual sound from his chest? Have you noticed that he stopped breathing for a few seconds? So that's called apnea. So it's very important to ask it, because in that way, examiner will understand that you are trying to rule out gastroesophageal reflux disease. And this you will also have to discuss in the red flag when you come for the management. Okay, so how we are going to manage this case? So most likely your child is having a condition called gastroesophageal reflux. Do you know what it is? No, doctor. Well, let me draw a picture for your better understanding. So this is, let's say this is your child's food pipe, and that's the stomach. So food will naturally go from the mouth into the food pipe, then to the stomach. But in this case, the lower part of the food pipe, where it gets connected with the stomach, is very poorly developed in babies. That's the reason why the milk in the stomach flows back into his mouth when you put him down. It is a very common condition where baby vomits after each feeding, but otherwise they gain weight, thrive well. This condition gradually improves with time, especially after introduction of solid food. And majority of cases, it gets totally clear up by 1 year of age. At the moment, what I'm going to recommend you is to change some of the way of feeding, and that can help. So you can give him a small frequent feeding rather than giving a lot of feeding at one time. Decrease the duration of feeding along with time in between. You can also thicken the feed with some food thickeners like Gaviscon. You can also elevate the head of the cot. After each feed, please do not put him immediately to sleep. Carry him for a while and put him in the cot with head elevated. We highly recommend breast milk because it is best for your baby. And because why we are asking it is that in here is written, mom thinks that bottle feeding will be better for him. So you just need to address that in your management. If it does not help him in few weeks, we can always refer him to a gut specialist who can start on acid suppressant therapy. But most of the time, it's not needed. So if you just follow this approach, you will be fine. I would like you to know, or I would like to reassure you that as long as your child is growing well, feeding well, there is nothing that you need to be afraid of. I will also regularly review him and I will give you reading materials about everything I have discussed. At any time, if you notice that he's getting pronounced irritability with arching of the back, is refusing to feed, losing body weight, getting cough, unusual breathing, or stop breathing for a few seconds while sleeping, please bring him back immediately. Okay? So that will be your 4R. So that's all about that gastroesophageal reflux. See that now the cages will be very short because now you know the format, you know the physical examination, and we just need to know the management. So that's how we make the cages very short for you. It becomes so easy. Let's take a 10-minute break now, and then we'll finish some of the other cages. All right? Any questions so far? You guys are understanding? The classes are not boring? All good? So let's take a 10-minute break. Thank you. All right, everyone, let's start again. So now we are going to discuss about pyloric stenosis. Pyloric stenosis is also an important case for your exam. Just hold on a second. So those of you who are in Facebook, if you guys have any questions, just feel free to ask it in the comment box. All right. So you are an HMO in the emergency department, 6 weeks old baby boy with vomiting brought by his mother. History, physical examination from examiner, explain diagnosis and management. So it's a 6 weeks baby having vomiting. So usually 6 weeks, 2 to 6 weeks is the usual time of diagnosis for pyloric stenosis. Now, positive findings in here is that the child will have a sudden onset of vomiting around the age of 2 to 6 weeks, and it's rare after 12 weeks. Vomiting will be a non-bilious kind of vomiting. Progressively, it will become more forceful and sometimes become projectile, often hungry afterwards. And the main feature is that inadequate weight gain or weight loss. So if a child having a non-bilious vomiting, which is forceful projectile, and every time you're feeding, child is vomiting it out and getting hungry after that, and also losing weight, think about possibility of pyloric stenosis. On physical examination, don't forget dehydration. You might get a gastric peristalsis on inspection, which is a wave of muscle contraction across the abdomen, sometimes passing from the left upper quadrant towards the right lower quadrant. Okay. You can also feel a pyloric mass, which is best felt in the right upper quadrant. And it feels like an olive-shaped mass. There is a test we can do called positive feeding test. So sometimes what you can do, you can ask the mother to breastfeed the baby, give her some privacy, and then you will see the child is vomiting it out. So if the child vomits and you can see the projectile vomiting in front of you, then you can also just think about the possibility of pyloric stenosis. So these are the signs and symptoms you will look for in your physical examination. So gastric peristalsis, pyloric mass, and ask for a positive feeding test. So management. So say that most likely your child is suffering from a condition called pyloric stenosis. Do you know what it is? No, doctor. Let me draw a picture for your better understanding. So you draw the same picture. Now in exam, your picture does not need to be perfect. Just draw it. Okay. So you can say that, well, this is your child food pipe. The milk that you give, it goes from the mouth through a tube-like structure called food pipe to the stomach. From this stomach, milk then goes to the small gut, right? In pyloric stenosis, the lower end of the stomach, known as pylorus, it gets narrowed. And as a result of that, the milk or whatever your child drinking, it cannot pass down to the small gut, excuse me, and your child vomits it out. And due to vomiting, he's also losing fluids from his body and he's not gaining adequate weight. So that's what we call as pyloric stenosis. Now, this is an emergency situation because if we don't fix it as soon as possible, your child will become more and more dehydrated and it can become life-threatening. And an operation is the only way to fix it. That's why I'm going to call the ambulance and arrange for a pediatric emergency retrieval team and transfer your child to the hospital as soon as possible. In the hospital, he will be seen by a child specialist for further assessment and management. Diagnosis is usually clinical, but sometimes a specialist might want to do an ultrasound of the abdomen to confirm. They will also do some other blood test to check his salt and mineral status and also acid base level. As your child seems to be dehydrated, I will start him on some fluid through an IV line. And also I would advise you not to feed him from now onwards because it can make the vomiting worse. If your child keeps vomiting even after stopping eating, they might also insert a tiny plastic tube through his nose into the stomach to remove the remaining content of the stomach so that he does not vomit anymore. Once your child is stable, then most likely an operation will need to be done to fix the problem. Your child will be able to start eating and drinking within few hours of the operation. But once the problem is repaired, it is unusual to come back again. Now you have been saying so much stressful thing to a parents, right? And it's just a 6 weeks old baby. Think that how much stressful they would be. So you will have to finish with some reassurance, some empathy. That's must for this case. Say that, Jenny, I understand that when you came here, you were not expecting any of this. And I can't even think how stressful this is for you. But I want to reassure you that your child is, but I want to reassure you that we will do our best to manage this issue. And I'm going to send him to the hospital where they will have a very good team of doctors who are experienced to treat this kind of issue. If you want me to call your partner, I would be happy to do so. If you have any questions, feel free to ask me. Feel free to ask the hospital team. They would be happy to answer any of your questions. I'll give you some reading material so that you can just read it on the way to your hospital. And please come and see me once your child is discharged from the hospital so that I can review him again. Okay, so say something nice and reassuring at the end for this kind of cases, because otherwise examiner thinks you are just here to pass the exam. You are not actually treating the patient. Okay, so that's very important. And you will need to say that, like, why this is emergency, why this needs an operation, that you will have to talk, which we have written in here, that this is an emergency condition and an operation is needed to fix the problem, because if it keeps on happening, your child will vomit everything that you're giving and he will not receive enough fluid or food. And without food, it becomes life-threatening for them. And the only way to open that narrow stomach is to fix it by surgery. There is no medication available. And as soon as we can do it, your child can become fine and he will again start to gain weight, just like a normal baby. So you will have to say this kind of thing so that they understand the urgency and they understand that why an operation is needed. Okay, clear, guys? Any question? As you can see from the way of our discussion, that when we discuss the management, we first explain what is the condition. We explain a little bit pathophysiology, like we try to explain the condition and we try to correlate the patient's symptom with the condition. And then we try to say that is it a common condition or uncommon condition, and we reassure after explaining. Then we go for further management. Further management, most of the time, if you're sending them to the hospital, say that why you are sending them. So you talk about hospital management. So admission to the hospital, seen by the specialist, then they will do some investigation, and then we talk about the management. Lastly, we will again reassure them and finish with 4R. So that's what we normally do. Okay. There is a thing that we use sometimes, if you want to remember, we call 5C. So condition, clinical feature, commonality, complication, right? So at least if you use this thing, like what is the condition? What is the clinical feature of this condition? Is it a common or uncommon condition? And in some stage, we discussed about complication, especially if we are sending them to a hospital, we need to say that what's the worst can happen and why we are sending them to the hospital. Okay. Moving on to intussusception. You are a HMO in emergency, a 5-month-old baby with multiple episodes of screaming for last 6 hours. So intussusception will come with a screaming and it will be a very sudden onset. He has vomited twice in the last 3 hours. Task is same. So history in this case, obviously you will do all the same thing. Your history of presenting complaint is screaming and vomiting. So you will need to ask a little bit more about the screaming. So can you please tell me a little bit more about these screaming episodes? You need to know since when it started, what exactly was he doing when it started? Because child might have ingested or inhaled a foreign body, or maybe playing with a toy and suddenly aspirated it. So we need to know what exactly was he doing when it started. Anything in particularly happened before these episodes? Continuous or episodic? How many episodes of screaming so far? And during this screaming, does he drop his legs? And does it turn pale? So that's your main questions for intussusception. Then you ask all the vomiting question and all the differential diagnosis question just like before. The main feature is this screaming episodes with vomiting of bile stained. So it will be a bile stained vomiting. And they can also turn pale during crying and that they can have a drawing of their legs towards the chest as if they're in severe pain during those screaming time. And you can get a loose stool, sometimes a classic red currant jelly-like stool. Physical examination will be same like before, but when you come to the systemic examination, like the abdominal exam, couple of findings you will be looking for. You can get distended abdomen. You will not get any visible peristalsis here, but on palpation, you can feel a sausage-shaped mass. Sometimes it can be only felt if child is crying or having screaming. So you can ask if examiners say no, and you are sure that this is an intussusception case, you can ask the examiner that, well, if child starts crying, can I feel a mass at that time? Sometimes if you do that, then examiners say yes. Ask about any emptiness in the right iliac fossa, which can be a feature of intussusception, tenderness, and auscultation for bowel sound. Sometimes in intussusception, you can get an alternating high-pitched vowel sound with absent vowel sound. Okay, so that will be the finding. Don't forget to ask about the per anal inspection here, because many times you will get this classic finding of red currant jelly on this case. There was a case in which the history was not that much good. So it was a very vague history given by the parents. Physical examination also quite normal. And they asked in the task that examine the child's perianal area. And they put a dummy of a child in the exam hall. You remove the diaper, obviously taking a consent from the parent. And then once you remove the diaper, you see this red currant jelly around the perianal area. That gives you a diagnosis at that time. Okay, so it happened. So you already know the positive history from here, so that's fine. You know the physical examination finding already. How you are going to manage this case? So say that based on the history and physical examination, most likely your child is having a condition called intussusception. Do you know what it is? No, doctor. Well, let's say that this is a part of his gut and that's another part of his gut. So it means that sliding of one part of the gut into the other. And because of sliding, bowel can get blocked or obstructed, leading to this excessive pain and vomiting that he has got. Okay, so be very simple. If you want to really discuss intussusception, patient will not understand anything. The best way is sliding of one part of the gut into other, causing blockage of the gut, and that's why the content of the gut is not moving forward, causing this pain and vomiting. This is an emergency condition because this part of the gut might not be able to get enough blood supply and it can become irreversibly damaged. That's why we need to admit your child to the hospital, and I will involve the pediatrician. In the meantime, please do not give any food or drink to your child. We will put an IV line and start him on IV fluid. Specialists might want to order a ultrasound and X-ray of his tummy to rule out any obstruction. Once it is confirmed, the treatment will be given by the specialist, which is the pediatrician, a radiologist, and the pediatric surgeon. Most commonly, they will try with the air enema, which is passing a small tube at his back passage through which air will be passed. And sometimes through this rapid pressure of air, this sliding of this gut can get unblocked. Please don't get scared about it, because throughout the procedure, your child will be monitored by the specialist and he will be in sleep. If this procedure not effective, then surgery might be needed as well. Please don't get scared. I understand that this is very scary for you. And I know that when you came here, you even did not think about it. But I do really appreciate that you have brought him as soon as possible. And with appropriate management, we can manage this condition without any future complications. And we have a very good team of doctors here who is going to take care of your baby. Okay, so say something nice and good at the end so that they feel reassured. You might be thinking that why we are not talking about surgery side effect or complications. It's not your job because you are a junior doctor. You just give the options, you just give a little bit of idea. Before doing the surgery or the procedure, specialist will discuss it anyway. So that's not part of your job. So you are just an HMO or RMO, so who is just there to initially talk with the patient. Further management will be done by the specialist. Okay. All good, guys? Any question with this intussusception case? All right, moving on to the next one, incarcerated hernia. Incarcerated hernia can be, the questions can be two kind. One, a 5-month-old baby came to your GP clinic with his mother because of sudden onset intermittent screaming with a few episodes of vomiting. Older brother has got recent onset of gastro. Now this is just to confuse you. Okay. Other one can be 3-month-old irritable baby for 3 weeks and mother noticed a lump on the inguinal area. So this becomes easy. Most of the time, this one comes in exam. So intermittent screaming does not mean that it will always be intussusception. It can be anything. Screaming means child is in pain. So don't just think that child is screaming, that means the child having intussusception. Okay. So in this case, your history will be same like before. You will start with the screaming, vomiting, and all other questions. Sometimes, even with the inguinal hernia, the parents might not even know that there is a lump in the inguinal area. So in the history, you might not get any finding. And then you'll be thinking that, have I missed something? If you ask everything and still there is no finding, just go to your next task, because maybe they're supposed to not to give you any finding. So in the physical examination, you do everything. Abdominal examination might be normal, everything might be normal. When you come for that inguinal hernia checkup, then examiner will show you a picture of incarceration. And then whenever examiner shows you a picture in the exam, always explain it, even if it's not the task. So you can just say that, I can see that there is a red or erythematous swelling in the inguinal area. You will need to ask it from the examiner. Dear examiner, I would like to know if it is tender to touch, if it is reducible or irreducible, and if the cuff impulse present or not, depending on the age of the child, if a child is able to follow the command. So a hernia is called irreducible or obstructed if the hernia is red, tender, irreducible, and absence of cuff impulse. So if all of these features are there, then you can diagnose it as obstructed hernia or incarcerated hernia. So explain that from history and physical examination, most likely your child is having a condition called incarcerated hernia. Do you know what it is? No, doctor. Well, a hernia is a protrusion of part of the gut or fatty material through a weak part of his tummy wall. It is usually seen as a bulge under the skin in his groin region. In a simple hernia, the bowel or the fatty content are able to move freely in and out of the defect. And that's the time we call it as reducible hernia. But if a part of the bowel becomes trapped and it cannot return to the tummy, it is at risk of having its blood supply to cut off. And that's the time we call it irreducible or incarcerated hernia. In your child case, it is red, very painful, and also we are not able to reduce it back to the original place. So most likely your child is having a obstructed or incarcerated hernia. Jenny, it is an emergency condition because unless we treat it urgently, the part of the gut which is outside will lack of blood supply and can have irreversible damage. That's why we need to admit your child right now. He will be seen by a child specialist for further management. Please don't feed him or give him anything to drink. I will put an IV line and start him in IV fluid. Most likely, specialist will go for surgery to put the blocked gut back inside. Please don't get scared. This is not an uncommon situation in a child. But when it becomes obstructed like that, it is at risk. But you did a very good job to bring him here as early as possible. And with our management, most likely he will not have any complications. The specialist will discuss the procedure of surgery in detail with you and also the complications of it. And then if you have any questions, feel free to ask me or the specialist as many times as you want. Okay. And lastly, give some 4R if you want. All right. So that's incarcerated hernia management. Now, do you guys have an idea that how many cases we have done with just single format? Just think that if you needed to do all these cases one by one without having a format in your head. So that's actually the way to practice for the exam. It's always how you learn it smartly, it depends. You can memorize 100 cases, but in the exam, because of the pressure, you will not be able to deliver it if you don't have a format in your head. The format makes it easier. Format will not just help you in the exam. Still now, when we see the patient, we still follow this format. So it will be a lifelong thing for you so that you don't miss anything. Next case, very important for exam, called duodenal atresia. So you are working in a small country hospital as HMO. You have been called to talk to a 27-year-old mother, Janelle, who gave birth to a baby boy 24 hours ago. She has started breastfeeding, but he has vomited several times some greenish fluid. and he hasn't passed meconium yet. The neonatal checkup did not reveal any pathological finding, especially anus was present, an abdominal X-ray is provided. Take a brief history, explain the X-ray finding to the mother, discuss the most likely diagnosis and management with the mother. Okay, so it's easy to remember that if it's a projectile vomiting, 2 to 6 weeks old baby, bilious, non-bilious vomiting, then we think about pyloric stenosis. If it's a bilious vomiting, very early or just immediately after birth, child is having this kind of bilious vomiting, think about duodenal atresia. Okay, so brief history in here, we'll be just asking about like the vomiting questions and ruling out some of the differential diagnosis, just like you have done. The history is same. This is the X-ray given. In the X-ray, what you can see is called a double bubble sign. See this one and this one. That's what we call as double bubble sign, classic picture for duodenal atresia. How to explain an X-ray, it's also an important thing. When we come to the explanation of X-ray, before we go for it, let me just go through your history a little bit. So as we know that we will ask the same questions, we will make sure child is stable. It's a good idea because the mother just had a delivery. Just ask that, how are you doing after the delivery? Are you alone? Do you need me to call someone to be with you? So just say something so that she feels that you are also taking care of her. Ask about the vomiting, associated symptoms. Ask that, do you know that if he has passed stool or flatus yet? Okay, has he passed urine? If they passed it, then you only ask the other question. Okay, and try to rule out all the differential diagnoses that we have done. Lastly, finish with binds and ask about social history, like, is your partner supportive? Do you have any issues? Okay, so it's the same questions, nothing different. It just depends, like some of the questions you might not need to ask because it's just a 24-hour-old baby. Like, how is his growth and development? For a 24-hour-old baby, growth and development question not important. Okay. So when you explain a X-ray to a patient, you will need to use simple words, not a medical jargon. So very simple. You in the face-to-face exam, you might have the X-ray in front of you, so you can just show this to the mother or the parents, and it becomes easy. So say that this is an X-ray of your baby's lower chest and the tummy. In X-ray, some shadows look blackish, some looks whitish. The whitish are mainly which consists of bone or which contains fluid or blood. The blackish are mainly which contains air. Now, if you look at this X-ray of your child's lower chest and tummy, you can see that on the upper side, this blackish shadow are his lungs. In the middle is his heart. Now, if you come to the abdomen or his tummy, you can see that there are two distinct blackish shadow. Can you appreciate that? Yes, doctor. Now, this classic shadow is what we call as bubble, or as together we call it as double bubble sign. When a child having this kind of shadows, it is most likely due to a condition called duodenal atresia, which is a type of a small bowel obstruction. Let me draw a picture for your better understanding. So you draw the stomach, you draw the duodenum and say that food comes from the mouth into the food pipe, then goes to the stomach and then goes to the gut. The first part of the gut is called duodenum. Okay. Duodenal atresia means that if there is an absence of part of this small bowel called duodenum. So that means that your child has got an absence of this part of the gut. Now, if this part is absent, anything that you are giving, your child will not be able to pass it through the gut, and your child will vomit it out. Now, this is an emergency situation because everything that you are giving to your baby is coming out and it can cause a life-threatening situation. Now, because we are in a rural hospital, if you come here, you can see that you are in a small country hospital. In the small country hospital, you can't treat this child. So what you'll have to say that because this is a emergency situation and we are a country hospital, we don't have enough equipment to treat your baby here. So we'll need to send your child to a tertiary hospital as soon as possible. I'm going to arrange an emergency pediatric retrieval team and we will send your child to the hospital by air ambulance. Your child will be assessed by a pediatric surgeon in the hospital and most possibly he will need a surgery to fix it. In the meantime, please don't breastfeed him anymore. We will insert an IV line and we will start some IV fluid. In the hospital, if he starts vomiting, they might also want to insert a small tiny tube through his nose into his stomach to remove any of the stomach content so that he does not vomit anymore. I know that this is what you haven't expected, Jenny. But sometimes things happen without your expectation. Sometimes this is just happens. There is nothing wrong that you have done which has done it, and there is no way we could prevent it anyway. But I want you to know that where I am sending your child, they have a very good experienced doctor. And to them, this is not an uncommon condition. They treat childs like yours regularly. So your child will be in a good hand. And with appropriate surgery, your child will be fine. The specialist will discuss everything in detail about the procedure. And if you have any questions, feel free to ask me or your specialist at that time. If you want me to call your partner or any of the friends or family members, please feel free to ask me. I'll be more than happy to call them. Okay? And give some reading material and say that you would like to review the child after discharge from the hospital. Now, you are in a rural hospital. You don't need to do that. You can just say that, just give the reading materials and just reassure them. Okay? So that's what we call as duodenal atresia management. And that brings us to the finishing of our tonight's session. Okay, did you guys get this duodenal atresia? Any question? All good. Now, you can unmute yourself. You can ask any questions because this is your last class for those 2 weeks free session. After that, all the classes will be just for the course student. Now, still our course admission will be open for the next 1 week. So if you still want to join the session, feel free to do that. What you need to do is either you inbox me and you can get my ID from First Aid AMC Clinical, where you can see all the posts. So either you inbox or you can also email us. Because this is our last session for those 2 weeks, we are going to show you that video for this course. And if you still have any questions after that, please feel free to ask me. Then for the course student, the next class will not be on Saturday. So most likely it is going to be on Wednesday. So Saturday and Sunday class already has been taken this week. So we will take your next class on 28th. So that will be on Wednesday. The full schedule will be given to your course Facebook group. So just have a look. Okay, so it will be given most likely tomorrow morning or in the afternoon. Main difference in terms of vomiting between duodenal atresia, pyloric stenosis, and intussusception. So as you know that duodenal atresia commonly happens in a neonate just immediately after birth. And the vomiting will be greenish fluid, like a bilious vomiting. And they can have an abdominal distension. Pyloric stenosis, it's a little bit more older child, like 2 to 6 weeks old. non-bilious vomiting, like it's not a greenish vomiting, and they lose body weight for it. Intussusception is totally different because it usually happens around 9 to 12 months, and they also give you greenish vomiting, but they have a sudden onset of screaming because of very severe pain. So screaming is the main feature in those cases. All right, now let's go through the course detail once more, and we can go through your any questions if you have. Just give me a moment. All right. All right, so that was all about this course. I hope that you guys enjoyed these 2 weeks free sessions. If you have any questions about the course, you can always ask us. And this is also the time where you can ask it. Any questions, anything that you want to know? All right then, so enjoy the Christmas and the New Year. Obviously, even before New Year, we'll have the classes with you. So that should be fine. All right, and I hope that in the new year, all of you pass the exam and you can start working in Australia. Thank you all. Have a good night. Bye.